This is chapter 29, head and spine injuries. In the first page of the chapter is your National EMS Education Standard Competencies. I'm not going to read these 4 slides to you. This is where they're going to go ahead and find your FSDAP questions and our EMT questions. Make sure you go through that material. I will be covering it as we're going through these slides, so I don't read these slides to you. We have already talked significantly about the nervous system, so we're going to go through the anatomy and physiology kind of quick because this is material we have covered in the past. You should already know this material, but we know that the nervous system is made up of 3 parts. We've got our brain, our spinal cord, and our nerve and nerve fibers. Brain is protected by the skull. Please remember that inside the skull is not nice and smooth, that there are a lot of bony prominences that stick out, that when we have an injury to the head can cause damage to the brain. Our spinal cord is protected by our spinal canal. We've got our central nervous system, that is the brain and spinal cord, and then our peripheral nervous system, that's all the other nerves in the body. Here's the example of the diagram of the brain and spinal canal nerves, showing how we're going to react, how the pathways are. We've got the sensory nerves, which send the impulses from the skin to the brain, and then we've got the motor nerves, which travel the impulses, travel through from the brain to the muscles, creating that movement. Your brain has 3 major areas. We got our cerebrum, our cerebellum, and our brainstem. The brainstem is in the center. It controls all of our basic functions necessary for survival. We've got our cerebrum. That is that great big gray matter. All right, it's about 75% of the brain's volume. We have 2 hemispheres, your right hemisphere and your left hemisphere. Your cerebellum is going to coordinate your muscles movements, your body movements, your balance. Your spinal cord, if you think of the spinal cord as an extension of the brainstem, the fibers come down from the brainstem through the spinal canal. All right, it comes out through an opening in the brain, in the skull. We've got the entire central nervous system is protected. We've got our cranium, our skull, which is protecting the brain. We've got our spinal canal or spinal column, which is protecting the spinal cord with bones. Then we also have meninges. It's like a sac that goes around the brain and spinal cord. The meninges is made up of 3 layers. We have our outer layer, which is called the dura mater. Then we have 2 inner layers. We have the arachnoid mater. That's where blood vessels are, and this cerebral spinal fluid flows through there. And then we have the pia mater. That is right up against the brain. This diagram shows you the difference, or this figure shows you where all the different layers are. We have CSF, cerebral spinal fluid. We have between 125 and 150 milliliters of CSF in the brain at any given time. It is produced inside the 3rd ventricle. It's a chamber inside the brain. It acts like a shock absorber. You have 31 pairs of spinal nerves. They're going to conduct the impulses from the skin and organs to the spinal cord, and the motor impulses go from the spinal cord to the muscles. The brachial plexus and lumbosacral plexuses are great big bundles of nerves, all right? We have the foramen magnum, where the spinal cord comes out from the brainstem. That is a large opening in the base of the skull. You've got 12 pairs of cranial nerves. You don't need to know what their names are. However, you do need to know that we have 12 of them, and it's a good idea to know their basic functions. Taste, smell, facial movements, hearing, sight are all some of the functions of those nerves. We've got our peripheral nerves. I've already talked about them, the sensory nerves and the motor nerves. We have connecting nerves. These are in the brain and the spinal cord. They connect the sensory and motor nerves with short fibers. Basically, think of it as a shortcut. So an example would be, take your hand, you put it on something hot. Sensory nerves send that signal up to the spinal cord, would go up to the brain. Because it's an irritant, that heat is an irritant, it is going to shortcut up at the spinal cord and send it right back down the motor nerves to tell you to move it away. It's a simple message. Hot, move it away. Irritant, stop. You're going to get hurt. Nervous system controls everything in the body. Your reflex activities, voluntary, involuntary activities, everything that the body does is controlled by the nervous system. Let's see, we've got that reflex arc, which I just told you about, that little short circuit, or shortcut rather. This shows how that works in this figure. Voluntary activities, we think about it, we do it. Walking, talking, okay? These are all voluntary activities. Involuntary activities, breathing, your heart beating, blinking. We don't think about doing these things, they just are done, okay? Your somatic nervous system handles your voluntary activities. Your autonomic handles your involuntary activities. You have your sympathetic and your parasympathetic. Remember, we've talked about these before. Sympathetic is your fight and flight. It's going to cause an increased heart rate. You're going to have your breathing will become faster. Your blood is shunted away from your digestive system towards your cardiovascular, or towards your heart and lungs, okay? In the parasympathetic, we call that rest and digest, all right? Your heart rate's going to slow down, your blood vessels are going to dilate, your muscles are going to relax. You have your skull, you've got your facial bones and your cranial bones, both create the skull. You guys need to know the name of the bones in the skull. Four major bones of the cranium is your occiput, back here, your temporal, parietal, and frontal, okay? You've got 14 bones in your face. Know all 14 of them. And your spinal column, you have 33 vertebrae. How many in each section? You should know that. All right, we have talked about this before. If you don't remember, figure 29-7 shows you exactly how many for each one. If we have an injury to a vertebra, it can cause paralysis, okay? Oops. Sorry, phone's ringing. Um, in between the vertebra, we have discs, cushions. I like to think of them like a jelly donut. All right, they've got substance inside of them. If you squish it, it's going to, like a jelly donut, if you squish it, it's going to go to the opposite side. That is how we have a herniated disc, okay, when we have a back injury. Your spinal column has mostly muscle around it, muscles and ligaments, okay. So when we have a head injury, it is an can be soft tissue, it can be bony structures, it can be the brain, it can be, a fracture, or it could be brain injury. All right. Head injuries account for about half of traumatic deaths. All right. Generally, a head injury is not going to be a standalone injury. You're going to have something else going on. There's going to be trauma in some other part of the body. When we talk about closed injury, just like when we talk about closed injuries anywhere else in the body, there is no opening to the brain. The skin is still intact, okay? Open injuries, we're going to have an area where we're actually having visible brain matter or fractures in the skull that are allowing the outside to get into the brain. Can cause significant bleeding, and there may be exposed brain tissue. Also can be caused by a penetrating trauma. A lot of times our injuries are caused by falls and motor vehicle accidents. However, you can also have them in sports-related injuries or in assaults. Table 29-1 is going to show you some general signs and symptoms of a head injury: lacerations, contusions, hematomas, soft area or skull depression on palpation, visible fractures or deformities of the skull, decreased mentation, confusion, irregular breathing, widening pulse pressure, slow heart rate, ecchymosis or bruising about the eyes or behind the ear, over the mastoid process, clear or pink CSF leaking from a scalp wound, nose, ears, pupils aren't reacting to light, unequal pupils, loss of sensation or motor function, period of unconsciousness, amnesia, seizures, numbness and tingling in the extremities, dizziness, visual complaints, combative or abnormal behavior, nausea, vomiting, posturing. When we're talking posturing, decorticate is when they're pulling in towards their core. Okay, they pull in. Decerebrate is when we go out. We're no longer protecting our core. Scalp lacerations, they can be something very minor. However, anytime we have a laceration to the face or scalp, because it's very vascular, we're going to have a lot of bleeding. Okay, so it can lead to significant blood loss if we don't control that. There may be a more serious injury underneath when you're palpating or attempting to put pressure. If there is any depression or crepitus or soft spot, do not put firm pressure there. If there's a significant amount of force to the skull, it is going to cause a skull fracture, or it can cause a skull fracture. Just like fractures in any other bones, we can have open or closed skull fractures, okay? An open skull fracture, obviously, we can see the bone. There's a laceration over it, just like any other laceration over a suspected fracture. we assume that it is an open fracture. Okay, bullets, penetrating weapons, usually are going to result in a skull fracture. Skull fracture signs and symptoms or signs. There may be deformities. You can see visible cracks in the skull. You've got bruising or ecchymosis under the eyes. We call that raccoon eyes, or behind the ear over the mastoid process. Right in this area here, you're actually going to see bruising up on the ear itself. Okay, that is called battle sign. This is what they look like. We've got a couple different types of skull fractures. A linear skull fracture, you're probably not going to see any physical signs. Watch for signs and symptoms of a head injury. This is going to be about 80% of all skull fractures. You need to have an x-ray in order to diagnose this. Then we have our depressed skull fractures. That's going to be a high energy direct trauma to the head. Usually it's going to be a blunt object, baseball bat, hammer, tire iron. Something is going to strike the patient in the head, causing that depressed skull fracture. Your frontal and parietal bones are the most common ones to have this type of fracture. One of the biggest concerns with this, and the reason that you're not going to put pressure on this, is because the skull fragments can actually be driven into the brain, causing further injury. All right, then you got your basilar skull fractures. This is going to be a high energy trauma. Usually that's going to be a diffuse impact to the head. So it's all over. It's not necessarily just in one spot. You're going to sometimes see CSF coming out of the ears or nose. You're going to have raccoon eyes, battle sign, or you may have raccoon eyes or battle sign. The CSF coming out of the ear or nose may actually look like bleeding. Okay, what you're going to do is take that gauze pad, touch it to it, open it up, and see if it has that halo effect where you've got that yellowish circle around the drop of blood. Open skull fractures, generally, they're not going to be just the only injury. All right, you're going to have other injuries also. The brain tissue is exposed to the environment, which increases the chance of bacterial infection. Then we have a higher mortality rate as a result. So with your traumatic brain injuries, these are the most serious of all head injuries. You can have either a primary or a secondary, so a direct injury to the brain or an indirect injury. Primary injury is you have that direct impulse, or direct impact to the head, all right, and the brain is instantly injured. Your secondary is as a result of additional issues such as hypoxia, hypotension, cerebral edema, intracranial hemorrhage, increased intracranial pressure, cerebral ischemia, infection. When we have that hypoxia and hypotension, they are the two most common cause of secondary brain injury, and it increases the death and disability of the patient significantly. Okay, these secondary injuries, they can occur a few minutes to a few days after the initial head injury. They're not necessarily going to be instantaneous. We can have the brain injured directly by a penetrating object or indirectly as a result of external forces. An example of that would be we have a motor vehicle accident, patient strikes their forehead on the windshield, the brain comes forwards and strikes the inside of the skull, then the patient's head whips back and strikes the headrest, the brain now whips back also and strikes the back of the skull. We call that a coup contra coup injury. It's going to strike the front and then the back. Your cerebral edema, it can be several hours before it starts to develop. Anytime the patient has low oxygen levels or becomes hypoxic, it's going to aggravate and worsen that cerebral edema. So we want to make sure that we keep them appropriately oxygenated between 95 and 99. Okay, we don't want to hyperoxygenate them. We also don't want it going below 90. All right. You want to monitor your patient for seizure activity. So one of the other issues we have with brain injuries or head trauma is increased intracranial pressure. Okay. The brain is inside a closed vessel. If we're putting more stuff in that closed vessel, the brain is going to get squashed. All right. It's going to get pushed up against the skull when it's swelling. I just got done telling you that the skull is not nice and smooth, that it has a lot of bony prominences. Pushing the brain up against those prominences, it's causing more injury to the brain. All right. Some signs and symptoms of increased cranial pressure is Cheyne-Stokes breathing. That's where they're not breathing normally. They're going to breathe and then have a period of apnea where they stop breathing, and then they'll breathe and have a period of apnea. Or we can have biot respirations, ataxic respirations. There is no rhyme or reason for these. They're going to breathe fast and they're going to breathe slow. They might stop breathing and then they're going to breathe shallow. They're going to breathe deep. It's just all over the place, okay? When we can also have decreased pulse rate, headache, nausea, vomiting, decreased alertness, bradycardia, sluggish or non-reactive pupils, decerebrate posturing, which is out, decorticate posturing, which is in, increased or widening blood pressure, and then Cushing's reflex. Cushing's reflex is 3 symptoms. It's increased blood pressure, systolic, decreased pulse rate, and irregular respirations. That is a sign of significant intracranial pressure increase, and it is a very bad sign for your patient. They are dying. So in addition to the swelling, we can also have bleeding inside the skull. Bleeding is also going to increase that intracranial pressure. We can have that bleeding in between the skull and the dura. We call that an epidural hemorrhage. Between the dura and the brain and the skull and the dura on the inside, we call that a subdural hematoma. And then we can have it within the brain, which is a cerebral hemorrhage. Okay, so this is your epidural. You can see that the bleeding right here is between the skull and the dura, but it's above the dura. And then we have our subdural, which is below the dura but above the outer surface of the brain. Okay, usually that's going to be fall or deceleration force. They have a sudden stop. There may or may not be a skull fracture with this one. And then we have the intracerebral hematoma, which is bleeding inside the brain. You can have a subarachnoid hemorrhage. That's bleeding that occurs in the subarachnoid space where that CSF fluid is circulating. It's going to cause meningeal irritation. Just like we see with meningitis, they're going to have that neck rigidity. They can't do chin to chest. They're going to have a severe headache. Usually it's going to be a result of trauma or an aneurysm. They're going to complain of a sudden severe headache, worst headache ever. As bleeding is increasing, they're going to start having signs and symptoms of increased ICP. If the subarachnoid hematoma is severe and sudden, such as with an aneurysm, a lot of times it's going to result in death or if they do survive, there's going to be permanent neurologic damage. So let's talk about concussions. It's going to be a blow to the head or face can cause a concussion to the brain. It's a closed injury with a temporary loss or alteration of part or all of the brain's abilities to function without demonstrable physical damage to the brain. In other words, you get hit in the face or hit in the head, and the brain kind of Control-Alt-Deletes for a second. All right, it kind of resets. About 90% of patients will not lose consciousness. They may or may not remember all of the incident that caused it to occur. They may have headache, nausea. They can be confused. They could have an amnesia. Usually it's only going to last a short time. They may have what we call retrograde amnesia. They remember everything but the events leading up to the injury, or anterograde amnesia. They don't remember anything after the injury. Okay. So when we're dealing with these patients, we want to ask them, do you have any dizziness, weakness, visual changes, nausea, vomiting, ringing in the ears, slurred speech, inability to focus, changes in their mood, in their personality, when we're talking about a contusion, that is more serious than a concussion because it's actually an injury to the brain. These patients can have longer lasting or possibly permanent damage. They may have all or any of the signs of, my apologies, of a brain injury. We can have other brain injuries, such as those arising from medical conditions, blood clots, hemorrhages, infections. You can have signs and symptoms of non-traumatic injuries. The signs and symptoms of non-traumatic injuries are generally going to be the same as a traumatic brain injury. All right. So if you guys have any questions, please go ahead and let me know. Send me a text, an email, or when we're in class again, go ahead and ask it. So with our spinal injuries, we can have a compression injury as a result of a fall or jumping off of empty countertops onto the floor. That can cause a herniation of the disc. Okay. Motor vehicle accidents can overextend the spine. We can also have that rotation flexion injuries from rapid acceleration forces. With those compression injuries from a fall, it can also be a direct blow to the top of the head, can cause that compression injury also. We can have hyperextension. We can have fractures in the spine, misalignment from the spine, ligament injuries with that hyperextension. When we do have an injury to the spine, it can cause the vertebra to move out of alignment. They can go backwards, forwards, or to either side. When we're palpating along the spine, that's what we're looking for, is any tenderness or misalignment. If we feel it, we want to make note of about where we found it, and we want to take spinal precautions in order to prevent any further damage or to reduce the risk of increased injury. Anytime we have a motor vehicle accident pedestrian versus motor vehicle. Falls greater than 20 feet for an adult or 10 feet for a child. Blunt trauma, penetrating trauma to the head, neck, back, or torso. We always want to be worried about a possible spinal injury or head injury, and we assume there is one until we prove otherwise. Okay. Rapid decelerations, hangings, axial loading injuries, diving accidents. I'm not talking scuba diving, I'm talking you jump off the diving board or jump off the side of the pool into the pool, and the pool's very shallow, you don't realize it, hit your head, causing injury to your head and neck. Make sure your scene is safe. Have your proper PPE. Call for ALS. Is it an MOI? Look at that. How significant was that MOI? How fast were they going? How much damage is to the vehicle? How high did they fall? These are all things that we need to look at to help determine how serious those injuries could be. All right? Treat your life threats first. Once we treat our life threats, we're going to maintain our C-spine and put them on a backboard if they need to, C-collar also. You're going to assess them how you found them. If you're attempting to put a C-collar on and their head is twisted sideways and you're trying to straighten it up and you meet resistance, leave it. Find another way to secure that. Do not attempt to force it into that neutral inline position. You're going to risk further injury. Get your general impression, your chief complaint. Departments are now starting to get away from putting patients on backboards all the time. We only use them when it's necessary. Reason being is it's not anatomically correct for your patient, okay? Especially geriatric patient or a patient with severe kyphosis, scoliosis. It can cause compromise of circulation. Some patients, especially your larger patients or larger chested women, can have difficulty breathing when we lie them flat because of increased pressure on their chest. So if we do have to put them on a backboard, we try and minimize it. Your cervical collar, like I said, we don't force the head into that neutral position. If we meet resistance, we do have to stop, and we will secure it in another manner. Once you put that cervical collar on, you don't take it off unless it's interfering with maintaining their airway. You're going to assess your patient for signs and symptoms of a head injury. How did it happen? Where does it hurt? Does your neck or back hurt? Can you move your hands and feet? Did you hit your head? If they have things like slurred speech, they're confused, repetitive questioning. Repetitive questioning would be, where am I? What happened? What day is it? What are you doing? Where are we going? These are examples of repetitive questioning. Anytime we have that type of questioning, you want to start thinking very seriously, this patient may have a serious head injury, okay? In the setting of trauma, we're going to assume they have a head injury until we prove otherwise by our assessment. You're going to look for your signs and symptoms of head and spine injury. If my patient is unresponsive, I'm assuming that they have a spinal injury because they cannot tell me otherwise. You're going to use that jaw thrust maneuver to open your airway. If you can't, last resort is that head tilt chin lift maneuver. Reason being is we don't want to be manipulating that spine any more than we need to. Be ready to suction our patient, because if they do have a head injury, they may start vomiting. Look for regular breathing patterns such as your Shane Stokes or your Biot ataxic to try and determine if there is increased pressure on their brain. Oxygen for these patients, you need to keep it above 90%. We generally aren't going to hyperventilate a patient unless it is for a very specific condition, and that would be determined by your protocols. You really don't want your patient to be below 95% when we are looking at our pulse ox. Make sure that we control their bleeding. If their pulse is too slow, it can indicate a very serious issue. Guys, a single episode of hypoperfusion in a patient with a head injury can lead to significant brain damage and even death. Assess these patients for signs and symptoms of shock. Rapid transport. ALS if you need them. Get your OPQRST sample if you can. If there's somebody around to give it to you, if the patient's able to answer those questions. Bystanders, any kind of medical ID bracelets or necklaces. Try and keep your patients still. You don't want them moving their head and neck. You might be doing a focused assessment, but generally we're going to be doing a systemic head to toe full body scan to look for any injuries. Get your vital signs. Make sure we are trending those vital signs. You want to do them about every 5 minutes, or if anything changes in your patient. You're also going to be checking their pulse, motor, and sensory, your neurologic status in their extremities. When we're looking at our vital signs, significant head injuries can cause the pulse to be slow and the blood pressure to rise. Now, when that blood pressure is rising, we're also seeing a difference sometimes in between the higher number and the lower number is going to get further and further. Okay, we call that a widening pulse pressure. That is a sign of Cushing's triad. When we have neurogenic shock, their blood pressure can drop and our heart rate's going to go up to compensate for it. All right, because from the area below the injury, there is no nerve impulses to keep those blood vessels working the way that they're supposed to. Make sure we're using our pulse ox and our blood pressure cuffs. Check for your DCAP BTLS. Check perfusion, pulse, motor, and sensory in all of your extremities. If they have a decreased level of consciousness, we're going to assume they have a head injury. Try and figure out if they're able to move their fingers and toes. You know, wiggle your fingers, wiggle your toes. In order to tell if we're wiggling our toes, we need to take the shoes off. You need to expose to tell. You're going to look for that CSF. Do you have any blood or fluid coming from the ears, nose, mouth? Look for the bruising around the eyes and behind the ears. Okay. Check your pupils. Are they equal and reactive? We don't put things in and we don't take things out. Don't put your finger in that scalp wound, okay? Leave it, because if there's bony fragments, you can push them into the brain. You can cut yourself. We don't probe wounds, okay? If there is an impaled object in the head, leave it in place. Secure it, stabilize it, and transport. We're going to use our GCS, that wonderful Glasgow Coma scale that everybody loves. Some departments use the revised trauma score. You're going to determine that from your GCS, okay? You're going to record their level of consciousness in your documentation. If it goes up or down, you want to document that. Anytime there's a change, document. All right, I am not going back over this. You guys need to know it. Table 29-2 is your GCS. We already covered this back in the neuro chapter. You're going to be checking your extremities for circulation, motor, and sensory. You're looking for any decap BTLS. You're going to go and palpate along the entire spine, feeling for any deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, or swelling. If we find anything, you're going to mark or note in your report where you found it. Do they have weakness or tingling in the extremities? Do we have any soft tissue injuries, especially over the spine? Keep reassessing your patients at least every 5 minutes. We're going to start back at that general impression, primary assessment, and work our way back down. You're going to treat the patient for shock, keep them warm, supine, and blanket. You're going to keep monitoring their neurologic status, monitoring their vital signs. If we have CSF present, okay, if you've got fluid coming out of the ears, the nose, or out of a laceration or a wound, you're going to cover it with sterile gauze. You're not putting pressure, you're just keeping it from having any kind of contaminant getting in there is basically what you're doing. Okay, you're going to give them high flow oxygen, C-collar, rapid transport. Let the hospital know what you're going to be bringing them in. Let them know the treatments. When you get there, you're going to document the treatments that you have provided. With these head injuries or spinal injuries, you should let the hospital know as soon as you can. Don't wait until you're 5 minutes out from the hospital and called in. Let them know sufficiently so that they can get the proper people in place. 3 things for head injuries that we need to make sure that we're doing. Make sure we've got an adequate airway. You want to control any bleeding. Make sure that there's adequate circulation. Assess their level of consciousness and continue to monitor it. That is the 3 things that we need to make sure that we're doing for our head injury patients. With our airway, we're going to use that jaw thrust maneuver. Once we open it, you're going to keep everything in that neutral inline position. Keep your C-collar on your patient. Secure them to the backboard. Once they are secured completely to the backboard, you can let go of C-spine. Not before. You hold it until everything is secured. This is what it looks like doing the C-spine. Make sure that any secretions or vomits has been suctioned from the airway. If there's any foreign bodies, you want them removed. Is my patient breathing? If so, are they breathing adequately? If not, we're going to assist them with ventilations. If they are, we're going to put them on high flow oxygen. Consider calling out my ALS. If they don't have a heartbeat, if they don't have a pulse, we're going to do CPR. If they are bleeding, it's going to increase the risks of hypoxia. We need to stop the bleeding, right? Direct pressure, unless there is crepitus underneath of it. If so, then we're going to stop. If we do have pressure on the head and our dressings become soaked with blood, we're going to add more dressings. We're not going to remove them. Shock, we're going to treat for shock. Usually it's going to be hypovolemia. You're going to transport them to a trauma center. Consider ALS. Okay, we talked a little bit about this Cushing's triad. It is very important to note the signs and symptoms and how we're going to treat it, and know that it is very serious. It is a major life threat. You need to transport rapidly. So Cushing's triad is increased blood pressure, decreased heart rate, irregular respirations, either the Cheyne-Stokes or those biots. Okay, you're going to manage shock, give them oxygen, ventilate as we need to. Do not hyperventilate these patients. Okay. You're going to follow your standard precautions for your spinal injuries. Keep their airway open while you're keeping the spine in proper position. Give them oxygen. Again, use your jaw thrust maneuver. If they have no gag reflex, if they're unresponsive, you can use an OPA. Have your suction ready, and you're going to give them oxygen. This is how we do that jaw thrust maneuver. It's actually easier for two people, one to hold the jaw thrust and one to ventilate the patient. Your spinal motion needs to be restricted. You're going to put the C-collar on. Do not allow them to move. Like I said to you before, do not force the head into a neutral inline position. If you meet resistance, you're going to stabilize it the way it is. Okay. And what I mean by resistance, if we have muscle spasms, if there's increased pain, numbness, tingling, weakness in their arms or legs, your airway becomes compromised, just stabilize them the way that they are. Put your C-collar on. C-collars are going to be uncomfortable. They are meant to be uncomfortable. It's to keep the patient from moving their head. Okay, you're going to make sure that you size it correctly and put it on properly. Once it's on, we're going to reassess our PMS in our extremities. You're going to continue to hold that C-spine until you're either put the patient on a backboard or a vacuum mattress. For spinal injuries, we're going to put them on a backboard or a vacuum mattress. The vacuum mattress is more beneficial, especially if we have a patient with significant curvature of their spine or kyphosis. We can use that vacuum mattress if they're seated or standing. We're going to carefully log roll our patient over, put them on the backboard. If we have a patient that is seated, we can use a short backboard in order to remove them from the vehicle or wherever they may be, unless we need to get to them rapidly. We need to get to a more serious patient, or their injuries justify an urgent removal. Okay, they've got more significant injuries and we're looking at life over limb. Okay. If we have a patient that's standing, we can go ahead and put them on the backboard if need be. We're going to first assess their spinal tenderness pain, check and see if they're altered, if they have any neurologic deficits, if there's any deformities, if there's a high energy trauma in an intoxicated patient, or if they have a distracting injury. The distracting injuries don't only distract us, but they can distract the patient and cause them not to necessarily realize that they got something else going on. If they've got a bone sticking out of their arm, they may not realize that they've got pain elsewhere because they're looking at this, getting all upset and excited about this bone sticking out. So we would call that a distracting injury, okay? You can use some of the devices we can use in addition to our short spine board, our long board, our C-collar, is this next one down here. That is a KED, or a short backboard they call it. This is a vest type. It takes a couple of minutes to put it on. You're going to use it for patients that are not critical. They're in the seated position. You're able to actually lift them up out of the vehicle or up out of that seated position and put them on the stretcher or a longboard. Then we've got this one here we call a scoop stretcher. What happens with this is at the top and at the bottom there are areas that you're able to open the pins up and actually separate this into two pieces. You slide one side under the patient and then the other side, and then lock them back together so that you're not having to manipulate your patient. These are just regular spine boards, long boards, back boards. Helmets. We don't generally take a helmet off unless it's impacting the patient's airway, interfering with our assessment, or with ventilation of the patient, or we cannot properly immobilize the spine. You're going to take the helmet off if it's a full face helmet. You can't assess the airway. You can't immobilize the spine. It's allowing for excessive head movement or your patient's in cardiac arrest. Taking the helmet off is always going to be two patients. Okay. The preferred method is first you're going to go ahead and contact medical control, discuss the decision to remove that helmet. If the decision is made that helmet's going to be removed, you're going to take, one person is going to be holding C-spine, the other person is going to take their hands and slide it inside the helmet after we've undone the chin strap. Slide it inside, pull out away from the head on both sides with your hands, and then gently slide it up off over the patient. Okay, that is the preferred method. We do have an alternative method. It's going to take a little bit longer, and we don't have to put as much force to do it, but it does take longer. So we've got advantages and disadvantages of the two. So with the alternative method, we're going to take the chin strap off, remove the face mask, take the jaw pads out, put your fingers inside the helmet. You're going to hold the jaw in one hand and the occiput in the other, so you're holding in the front and in the back. You're putting the padding behind the occiput, back of the skull, and you're going to try and slide it up. The person at the chest is going to be holding the head and neck so that they do not move. Now, anytime that we're backboarding a child or a patient that has kyphosis or deformities, we're going to need to put padding in to fill those voids. All right. If you guys have any questions, please feel free to email me or bring them up when we see each other in class. Have a great day.